Sina is getting ready to deliver a baby now. Physiologically, she goes through the cardinal movements of labor, and the baby will be coming out within the next 2 minutes. Some of the features about her, she's really important for team training in hospitals, for nursing, schools of nursing, and schools of medicine, because what she can do that no other mannequin can do is simulate a true shoulder dystocia. Shoulder dystocia is a medical emergency. The baby's not delivered within 7 minutes, you have risk of irreparable neurological deficit. Besides that, if it even takes 3 to 4 or 5 minutes to find how much cord compression takes place, you could have very poor outcome. And depending on how much torque or tension is applied to the baby's neck can also cause damage, brachial plexus palsy. So what she has available to her is palpable contractions. You can listen to the heart tones with a stethoscope, but she has an observable pelvic tilt. By moving her hips back, you can visually see her pelvis tilting in the McRoberts position. Roberts position is bringing the knees to the ears. That opens the AP diameter of her pelvis by 1.5 centimeters, which is enough to sometimes allow that shoulder to come through. The second maneuver is if the McRoberts doesn't work and a doctor calls or a provider calls, I've got a shoulder, is to palpate for the symphysis pubis, which she has palpable, and then to apply suprapubic pressure to help allow that shoulder to come out from underneath that stuck symphysis pubis. She's delivering the baby now. If I were calling a shoulder, the head would come out, rotate, and then turtle back, which is the first sign of a shoulder dystocia. We don't have her programmed in for that. She's just going to deliver vaginally, but I can talk you through what would happen is the head would come out, rotate, go back in, and shoulder. We'd call this shoulder. Here's the shoulder. The head would turtle. We'd say McRoberts. The other practitioner would grab her thigh, and we'd put her into the pelvic tilt, which might help. If that wasn't enough, then a third person would come in and do the suprapubic pressure, and then the baby would release and be able to be delivered. Okay, she's not a shoulder, so she will be delivering with the next contraction, but you can see how this would be an important drill for every hospital, every labor and delivery department, every school of medicine to have to deliver the baby and show how much traction force took place. What she has is superimposed underneath the baby cry. And the baby cries. And then we have APGAR scores that say 10-10 because I did a marvelous delivery. But, turn the baby over, thanks. Then I can deliver the placenta. When I worked in a hospital as the advanced practice nurse for high-risk labor and delivery, we ran shoulder dystocia drills regularly. The first thing that my risk department would ask me when they'd get a shoulder case in is, Carla, will you review the records? Tell me, how liable we are, and when was the last time you did shoulder dystocia drills? That's huge, either for the plaintiff or the defense when it comes to a shoulder dystocia case. But with the case of having a simulation mannequin like Lucina, where your staff is trained to drill, they can see how much force has been placed on the baby's neck. They can actually physically do the maneuvers that need to be done correctly, physiologically correctly, to deliver the baby. She can also go through Rubin's, Wood's corkscrew, delivery of posterior arm, and Zavanelli maneuvers if necessary to deliver the baby in the shoulder dystocia. So if you have any questions about shoulder dystocia cases, you need a case reviewed by an expert OB neonatal nurse, give me a call at Legal Nurse Consultants USA. Thank you.